64-year-old gentleman who presented to me for further management. Came to me with shortness of breath, productive cough, chest pain, fatigue, was having some weight loss and some anorexia. In terms of his past medical history, really not very significant, only hypertension, very well controlled with medications. Of note, he was a never smoker, no illicit drug or substance abuse. On physical exam, he appeared tired, but really nothing remarkable. On chest auscultation, there were decreased breath sounds on the left side. We proceeded with further imaging. Chest X-ray showed a left lower lobe mass. This was followed by a CAT scan that showed a 4.7 centimeter left lower lobe mass with hilar and mediastinal lymphadenopathy. A PET scan was subsequently done that showed FDG avidity in the left lower lobe mass and also in the mediastinal and hilar lymph nodes. And in addition, there was a left adrenal metastases that was confirmed. MRI of the brain was subsequently done that did not show any brain metastases. So putting all these pieces together, the patient was staged to have a stage 4 non-small cell lung cancer, T3N2M1A, with an ECOG performance status of 1. Bronchoscopy was performed and transbronchial biopsy of the left lower lobe showed pulmonary adenocarcinoma. However, the tumor tissue was minimal, insufficient for gene sequencing, and subsequently a plasma-based next generation gene sequencing was performed that showed an EGFR exon 19 deletion. So this patient was then started on first-line osimertinib at 80 milligrams a day. I saw the patient back in about 3 weeks for follow-up and tolerating it beautifully. Shortness of breath had improved, and so we continued on therapy. The first CAT scan was done at the 3-month time point that showed a partial response to therapy, and the patient continued with restaging scans performed every 3 months with follow-ups with us. Scans at 6 and 9 months continued to show a response. However, unfortunately, at the 18-month time point, we saw the presence of a new solitary liver nodule that was highly suspicious for metastatic disease. The initial impressions of this case are a 64-year-old gentleman with metastatic non-small cell lung cancer with a driver mutation in the EGFR domain. Even though stage 4 non-small cell lung cancer is not curable, it is highly treatable, especially in the setting of driver mutations that we can target with very active drugs.